When you look to the lateral surface of the skull, you can see two H-shaped configurations located on both sides of the squamous bone. This is the squamous bone. The red circle refers to the pterion, while the blue circle refers to a region that contains a very important craniometric point called asterion. Both of the pterion and asterion are used in neurosurgery language during localization of the lesions and during planning of surgery. Let's start by speaking about the pterion. But there is a very important concept that we should have about it. The pterion is a region. I mean, it is not a single point. It is the region where four bones meet together and unite to each other through the sutures. The greater wing of the sphenoid is the central bone in this configuration, and the other three bones unite around it. Of course, you can expect now and remember the names of the other three bones: the frontal, the parietal, and the squamous bone. By the way, we need to know the origin of this name, pterion, and why this region is so called pterion. What does it mean? The word is derived from the Greek origin pteron, which means wing. This is because in the Greek mythology, Hermes, who is the messenger of the god, had wings attached to his head, and these wings were fixed to his head at the same region of the pterion, so that this region is called pterion. The greater wing of the sphenoid is the center of the pterion, right? So that any craniotomy centered over the greater wing is called pterional craniotomy. So if we look to that axial cut of the skull, the greater wing is here. And if we make it the center of our work, then we will get that area of bone removal. It is a very big area of entrance. Yes, this shaded area represents the space that the pterional craniotomy can give us. I think you have noticed that you can reach the contralateral side to a lesser extent. So any structure located in this area can be easily reached through the pterional craniotomy. But of course, we can minimize our area according to our needs. And in this case, it can be called mini-pterional craniotomy. This is not the only advantage of the pterional craniotomy. There is another important surgical advantage. Look with me. The normal locations of the critical structures are very familiar through this approach. It gives us a good visualization of the optic nerves and optic chiasm and the surrounding structures of them, especially after wide opening of the sylvian fissure. This advantage becomes crucial when a tumor such as craniopharyngioma has completely displaced or encased these structures. But nothing without limitations. There is a big disadvantage in the pterional craniotomy. It is the cella and the third ventricle. You cannot easily visualize the intracellular components and the third ventricle region through this craniotomy. This is because of the angle of view. The cella will be inferior to the horizon of your sight, and the third ventricle region will be superior to it. The structures medial to the ipsilateral ICA will be very difficult to maneuver because the artery itself will become an obstacle to you. For example, the solid component of the craniopharyngioma, which is usually intracellular, will be very difficult to be excised. Also, the part of craniopharyngioma which is extending upward to the third ventricle will be difficult to reach without maximal retraction of the brain tissue. And this is the reason why sometimes we need the orbitozygomatic approach. But this is not our deal in this video now. Now let's go to the asterion. The origin of the word asterion is the Greek word aster, which means star. Now we understand the cause of the name. The asterion is star-shaped. It's formed by the meeting of parieto-mastoid, occipito-mastoid, and lambdoid sutures. The asterion is of great importance during posterior fossa surgery, especially the retrosigmoid craniotomy, because it represents the site of transition of the transverse sinus into the sigmoid sinus. This is just a change in the direction of the same sinus. I mean, it is over the sinus knee. In most cases, it's exactly present above the inferior third of the transverse sinus. In the retrosigmoid craniotomy, we need to just expose both the transverse and the sigmoid sinuses, because this confirms the best site of entry to retract the cerebellum without violating or contusing it. The asterion is an ideal point to quickly expose both sinuses using one per hole. In some cases, the asterion is less reliable, especially when the sigmoid sinus runs within the mastoid bone, and then the sigmoid sinus will not appear after perholing the asterion and will need partial mastoidectomy for exposing it, but these cases are less common. If we look to the site of asterion in relation to the external ear, it is located here. Now we are very close to expect the site and the shape of incision for the retrosigmoid craniotomy. If the sinus knee is here, the transverse sinus is here, and the sigmoid sinus is here. And so to expose both of them, we will need this incision, which is parallel to the curve of the ear pinna and nearly equal to its length, or a little bit longer by some millimeters. Now we reached the end of this part of craniocerebral topography, and this is to be continued. Thanks for watching.